Hello, friends. Welcome to this new feature, which is Psychiatry Education Forum Academy's updates. As you know, I post updates on our blogs, but this is our first video discussion of recent updates. So this will be available for free for everybody, but let's discuss this. This is an exciting news that FDA has approved this first oral rapid acting antidepressant for major depressive disorder, and this is called Auvelity. I hope I'm saying it right. But we know ketamine is one of the rapid acting antidepressant, but this is the first oral one. So let's see what this medication is about. And friends, I am Dr. Harvinder Singh. First of all, I have no disclosures. I'm not getting any money or anything from this pharmaceutical company. This is just for educational purposes. And I'm using all the references from the articles published on this medications, their package insert, and the information available on the website. And you can actually, if you're watching this on our website, you can scroll down, look at all the references, but I will put references in the end as well. So this is what I will discuss about Auvelity. But first, let's discuss the indication. What is this indicated for? So this is actually an indication for major depressive disorder in adults. Uh, and I looked at this indication. Please make a note that this is not for treatment resistant MDD. So this is for MDD. So I'm hopeful insurance companies will not cause problems when you decide to use this early on rather than after failure of certain antidepressants. But also make a note that this is not studied in geriatric population, and also it's not studied in pediatric population, so it's not approved for use in either of those. But I have to say this warning, which is really vital before we move forward, that there is a warning for suicidal thoughts and behaviors in pediatric and young adults, based on past short-term studies for antidepressants. So always stay cautious. But this is the indication, right? In adults only for now, and MDD. But let's see the mechanism, right? What is this medication? What does it contain? How does it work? So let's break it down. So, what is Auvelity? So, this is a combination of these two medication. So, dextromethorphan and bupropion. So let's see how these, why they use two combination. Bupropion is already an antidepressant. Um, why will you add dextromethorphan to bupropion? Or I should say, why will you add bupropion to dextromethorphan? And the reason is this. First, let's talk about dextromethorphan. Like, how does it work? So, friends, the basic mechanism is working on the glutamate pathway. So we know that glutamate is one of the major excitatory neurotransmitter in CNS, right? So with depression, we need excitation. We need these excitatory neurotransmitter glutamate to go up. And ketamine is one of those medication that works on this pathway. But dextromethorphan is an NMDA receptor antagonist. It's non-selective, non-competitive NMDA receptor antagonist. Actually, I can make a full lecture on this, but there are so many theories how these medications that blocks NMDA receptors helps with depression. One of the major theory is that in major depressive disorder, glutamate is reduced in our dorsolateral prefrontal cortex and some other areas of prefrontal cortex. So we have to increase that glutamate there. And one of the way we can do that is by altering the inhibitory tones of interneurons. Now, I wish I have a way to draw this, But there is a presynaptic neuron and postsynaptic neuron, right? That's how they communicate through synapse by releasing neurotransmitters. But there is also an interneuron on the presynaptic neuron. It's a GABA interneuron, and there are NMDA receptors on that. So by antagonizing the NMDA receptors on interneuron, these medicines alter the inhibitory tones of the interneuron. So they're like autoreceptors, but I don't know if I should call this as an autoreceptor. But by altering the inhibitory tone of these interneuron, we these medication blocks the interneuron activity, thereby causing disinhibition of the pyramidal neuron, and it enhances the glutamatergic firing. So that's one of the theories how glutamate goes up. And the other is it acts on postsynaptic NMDA receptor directly and causes this glutamatergic increase. So that's first mechanism how dextromethorphan works. And I think dextromethorphan is the main medication here with the mechanism for Auvelity. But there are other ways dextromethorphan helps. First is NMDA receptor antagonist, right? The second is it is also a sigma 1 receptor antagonist. What? You will say sigma 1, right? That's new. Well, it's not new in research. There are so many studies which have shown that these sigma receptors have a potential for the antidepressant medication in terms of fast onset of action, as this produces rapid modulation of the serotonergic system in the dorsal raphe nucleus and the glutamatergic transmission in the hippocampus. So, antagonizing sigma 1 receptor does glutamate and monoamine signaling. But I just want to make one more point. It works on the serotonin system as well through sigma 1. And we need to be mindful of that, especially with the risk of serotonin syndrome with these medication when you combine this with something that has serotonergic property, or you give higher doses of these medication. This was just a segue, but the second mechanism is sigma 1 receptor antagonist. And I was reviewing literature on sigma 1 receptor, and the data says you need to higher dosing of dextromethorphan for this action on sigma 1. I think that's why they chose the dosing that I will talk in few minutes. But that's the likely mechanism number 2, by antagonizing sigma 1 receptors. And third is it is a non-selective serotonin reuptake inhibitor. So you see there are two mechanisms here that increases serotonin. So be cautious of serotonin syndrome risk at higher doses or when other medications are added to Auvelity. Now, moving on to our next medication combination, bupropion here. So we all know what bupropion does, right? Everyone has used this medication. It's a selective norepinephrine and dopamine reuptake inhibitor. But the main reason why they added bupropion is this. It's a cytochrome P450 inhibitor. But why is that important? It's important because dextromethorphan gets broken down very fast by cytochrome P450 enzymes. So bupropion blocks that. Thereby, it uh, makes dextromethorphan available for longer duration. Thereby, we can see all the benefit on the left side through the mechanism of action. And when they give this combination, the steady state plasma concentration is achieved within 8 days. So it's a very quick reaching medication. So, friends, this is the basic mechanism of action of this medicine. I hope this was not confusing. I tried to put diagrams here, but then it was making the slide so much confusing. That's why I decided to do it this way. So, this is the mechanism of action. Now, moving to the next slide, which is, I think, the most clinically relevant slide, how to dose this medication. But before you dose this medication, you need to be really mindful of these three things. Like you should check these three things before you even give this medication. Number one is the blood pressure. You need to monitor periodically before starting the medication and during periodically during the treatment. So blood pressure can go up, so be mindful of that, and even go down actually when I was reviewing. But we'll talk about all that in few minutes. But the main risk is for hypertension, which is due to the bupropion component of Auvelity. And we have seen this, like when bupropion was tested for smoking cessation, hypertension was one of the risks there. So, and the risk increases at higher doses or when you add another medication that works on dopamine, you know. So, the basic thing you will learn in this discussion is be mindful of the dose and be mindful of drug interaction. If you stay mindful of that, you will be good. So, number one is blood pressure monitoring for the risk of hypertension. Number two is obviously bipolar disorder. You know, you need to do this evaluation first time, personal history of bipolar mania, hypomania, or family history of that because of the mood switches that can happen or non efficacy, right, with bipolar disorder and antidepressant use. And number three is drug interaction that I just mentioned, to make sure that their patient is not on other medication that contains bupropion, dextromethorphan, or causing dopamine or serotonin syndrome risk. So once you have done that, you start the medication. But what is the dose? I think this is the most important question, right? What is the dose of each of these in Auvelity? So one pill, I don't know if I should call it pill or a tablet. I should have looked that up. But one pill is equal to 45 milligram of dextromethorphan and 105 milligram of bupropion. Now, initiating dose is you give one tablet. It's a tablet, I think I should have changed that. But it's one tablet once daily in the morning time for 3 days. And after that, patient will make it twice daily, at least 8 hour difference. You know, after breakfast and after dinner should work. Now, but this recommended dose will change in three scenarios. What I mean is the recommended dose instead of twice daily should be only once daily. So you don't increase the medication after 3 days in three scenarios. Number one is patient with moderate renal impairment, right? Patients who have EGFR between 30 to 59, you just stay on once daily. And then patients who are on strong 2D6 inhibitors, I'll talk about that in a few minutes, or patients who are known 2D6 poor metabolizers, right? You have a genetic testing done and you know they are poor metabolizers, you don't go to twice daily. And I think you already know by now why 2D6 is important, right? That's how the bupropion is blocking this and preventing the breakdown. And if a patient is already on 2D6 inhibitor or they are poor metabolizer, the risk of dextromethorphan toxicity is high. And I'll talk about that as well in a few minutes. Now, my other thought is always, I think the biggest issue with this medication will be insurance, prior authorization. Um, I think we should also consider prescribing these two individually, also, right? So, like bupropion, either SR or XL formulation at 150 milligram and close to same dosing of dextromethorphan and combine them. That should work. I don't see a reason why not, but I think it's too early to comment on anything like that. But moving on now. So, this is the usual dosing, right, of Auvelity. But how about in special population? What to do of that? So, starting with our renal impairment, we just talked about this little bit, but patients who have moderate renal impairment that we just talked about with GFR, EGFR between 30 to 59, you recommend only once daily dosing. You don't go to twice daily dosing there. But a patient who have severe renal impairment, actually they did not study Auvelity. It was not evaluated in severe renal impairment, so they're recommending, to avoid, or it's not recommended in severe renal impairment. How about hepatic impairment? Well, in mild to moderate, no dosage adjustment is needed, so you can go to twice daily dosing. But in severe renal impairment, again, it's not evaluated, so they're not recommending right now. How about pregnancy? Now, this is really interesting and I think important that it's not recommended. Based on animal studies, they have found Auvelity may cause fetal harm when it's given during pregnancy. But also, they made a note that the separate effects of dextromethorphan on developmental toxicity at this dose is not clear. So they are very strongly writing this that use alternative treatment for a female who's planning to become pregnant. But if a female becomes pregnant while they are on Auvelity, you should discontinue the treatment and counsel the patient about the potential risk to fetus. I think this is something really interesting for a female of childbearing age. This discussion should be done on day one when this medication is discussed. That the data is limited. It may change with time, more research, but right now we need to be cautious of that. And then for breastfeeding, it's again not recommended during the treatment or at least for 5 days following the final dose. So let's say you decided to stop, it should at least be 5 days of no medication before breastfeeding can be resumed or continued. So, but again, they say it's not known whether dextromethorphan is present in human milk. There is no data of the effects of dextromethorphan on breastfed infants or any negative effects on milk production. But because of the potential for the neurotoxicity, they're advising that patients should not breastfeed on Auvelity. So this is, I think, really clinically important discussion here. But again, I will say this: it's not studied in pediatric and elderly, so it's not recommended right now for that age group. It's only for adult MDD. Now, moving on to the next topic, which is what are the common adverse reaction, right? This is a very important question that I think every patient will ask us when you decide to do risk versus benefit decision. Like, what are the common adverse reaction? So actually, found some pictures to make it more easy for us to remember and discuss this. So the most common side effect they found in clinical trial is dizziness. Like it was close to 16%. The second is headache, which is close to 8%. So you can see the difference. Dizziness is one of the most common side effect, which I believe is due to dextromethorphan component of the medication. So you should advise your patient that it may cause dizziness, to be very cautious, reduce any risk of fall, especially while driving or doing heavy machinery. So this is something you need to discuss, really important with Auvelity. Dizziness is one of the common side effect they found. Second, as I just said, is headache. So dizziness was 16%, headache is close to 8% in clinical trials. And then after that was diarrhea, GI side effect. And then it was dry mouth. And then somnolence, right? Sleepiness, which I think is also due to the dextromethorphan component to it. And then hyperhidrosis, sweating, which is likely due to the serotonergic component, which we have a chapter on that. You can read on that as well. And then it was sexual dysfunction. Now, this is likely due to dextromethorphan, in my opinion, because bupropion is one of the safer one with this side effect. So I think this has more to do with the serotonergic effect of dextromethorphan that we just talked about. So these were the common side effect. But what are the contraindications? Oh, before that, sorry, let me back it up. There are a few other warnings and precaution I want to go over, and I think these are really important one. The first is psychosis, which is, we all know, The bupropion at higher doses can do delusions, hallucinations, psychosis, concentration issues, paranoia, and confusion, right? It's very well known due to the dopamine component of that. But dextromethorphan in an overdose or when used in a higher dose can cause toxic psychosis, stupor, coma, and hyperexcitability. I think with this medication, we need to be really good with the physical exam component of dextromethorphan toxicity or overdose because it can present like this. But the and also if you use any other medication, right, which has the risk of causing the increased serotonin tone or dopamine, then it can do that. But the key is it's dose related, so you need to be really mindful of what dose the patient is taking. Always check on that. Or if a patient is using something else that contains bupropion or dextromethorphan like or mechanism like products. So that's one of the warnings. The other warning is for angle closure glaucoma. This warning is for other antidepressants as well. So the basic theory is the bupropion causes pupillary dilation, right? So in a patient who has anatomically narrow angles, they can trigger these angle closure attacks. So be mindful of that. And so, ideally, we should avoid in patients who have untreated anatomically narrow angles. And for that, you need help of your ophthalmologist or patient's history if they know about this before that. Now, I will talk about contraindication. These are the one that I think you already know before, but it's really important to go over them right now. First contraindication is seizure disorder. We already know how bupropion causes seizures, but this is dose related again. But it's not only dose, but you need to be mindful of patient factors, their clinical situations or the medication that they are using, or there is a risk of withdrawal, which is a second contraindication. If a patient has abruptly discontinued alcohol, benzodiazepines, barbiturates, or anti-epileptic drugs, the risk is high. And then you prescribe Auvelity on top of that, that's a big no. So please be mindful of that. And then, obviously, again, this is a bupropion contraindication, current or prior diagnosis of bulimia or anorexia nervosa. And then, obviously, with the MAOI inhibitors, you should not use them with or within 14 days of stopping MAOIs. So at least 14 days, 2 weeks must elapse between stopping MAOIs and starting Auvelity. And same goes on the other side. 14 days must be allowed after stopping Auvelity before you start MAOIs. So be mindful of that 2 week mark. Now, obviously, if a patient is sensitive, allergic to this, you should not use either of the component, right? Now, the drug interactions. And I think for drug interaction, you already know the cytochrome P450 enzymes we need to be mindful of. Starting with the 2D6. First, if a patient is on strong 2D6 inhibitors like fluoxetine, paroxetine, you should stay on once daily dosing. I think I mentioned that actually. I forgot. And that first screen and the dosing, right? 2D6 inhibitors, you stay on once daily. You don't go to twice daily dosing. Or if a patient is on 2D6 substrate, right? That can increase the exposure of drugs that are substrate for 2D6 because bupropion is blocking that. So be mindful of that. The second is 2B6, which is how the bupropion acts. So if a patient is on strong 2B6 in inducers like carbamazepine, phenytoin, there are antiviral also, I think efavirenz, you avoid use of this medication there, or you avoid 2B6 inducers to be added to that. And the other important drug interaction is digoxin. So this is really important that literature have shown that digoxin exposure was decreased when a single oral dose was given within 24 hours after the extended release bupropion in healthy volunteer. So this is again a bupropion interaction here. So it may decrease the digoxin level. So you need, if you do it, you need to monitor digoxin level closely with that. And then other drug interactions are very straightforward. Other medication that reduces seizure threshold should be avoided, or for obvious reason. And other dopaminergic medications, because that can do these CNS toxicity. So this was drug interaction, very straightforward. I think you know by now why we are cautious of these drug interaction, and that's why mechanism of action is so vital. And then important clinical facts about Auvelity. First is effects of food. Can you take it with food, without food? Uh, they say it can be taken with or without food. There was no major changes on Cmax or area under cover taken with or without food. But I always recommend take it with food. You remember one of the side effects was diarrhea, which was I think third or fourth common side effects. So with any medication doing that, or having, there were actually nausea also, which was not in the common side effect range, but it did happen. I always recommend any medications, always take it with food, so breakfast and dinner. And then important is risk on QTC. There was no risk of prolonging QT interval here, so very good there. But this is important. There is a risk of false positive urine drug test for amphetamines, which is from the bupropion component of Auvelity. Now I'm almost done with the presentation. The last aspect is Auvelity a rapid acting antidepressant? It is actually. But what is the data? Like why, how did they came to this conclusion? I will actually discuss two main studies that were done to prove this point. The first study was actually just published in Journal of Clinical Psychiatry. This is the Gemini study. This is a phase 3 of the randomized control trial on this medication. So Auvelity was called AXS05 before it came to Auvelity. So if you do literature search for this name, you will find all the studies for that. So this was a double-blind phase 3 trial, 327 patient randomized to either this AXS05 or to placebo. 6 weeks of duration, but note that this is with placebo or as a control. And this is what they found, that Auvelity was superior to placebo. And you see, it started from week 1, statistically significant results with the MAD-RS improvement, which is the depression scale that they used for the endpoint measurement. And response rate at 6 week was persistent. Definitely much better than placebo. You see 54% for Auvelity and 34% for placebo. So this is a one study, very major study. But let's discuss one more study. The reason I chose this study is, again, you see 2022 American Journal of Psychiatry randomized controlled trial, a very similar design, but this was multi-center 6 week study. But here the comparison was with bupropion sustained release 105 milligram. First one was with placebo, right? This is with bupropion. And they found the MADRS score change was significantly greater than bupropion at week 2 and every time point afterwards. So definitely it's not bupropion alone that's doing it, right? So by week 2 you saw the response here. And then remissions were significantly greater again at week 2 compared to the bupropion group. So friends, these are the references, and I will put everything below on our website also. So if you are watching this on YouTube, you can go to psychiatryeducationforum.com, go to our blog section, and you can find this references, this post with the references and everything there. But I hope this was helpful. Looks like I spent almost close to 30 minutes on this whole presentation. Again, this is available for free, but this is a new thing that I'm trying to experiment for our academy members. Any new update comes into in psychiatry, I'll try to make something like this. Please let me know if you find this helpful. But friends, this is Dr. Singh signing off now. You all take care. Bye for now.